Welcome to the Funnel Effect. Today, we are undertaking a really critical deep dive into one of the most immediate and devastating conditions in all of medicine, cardiogenic shock. This isn't just a tough topic, it is an ongoing medical crisis. Our analysis today is based on a foundational review article in the New England Journal of Medicine. It's titled simply Cardiogenic Shock, and it's authored by Holger Thiel, MD, and Christian Hassiger, MD.
And the mission for this deep dive is, well, it's clear and it's urgent. Cardiogenic shock, which at its heart is the catastrophic failure of the pumping mechanism, it remains a major unsolved problem. Despite decades of breakthroughs in cardiovascular technology and, rapid diagnosis, we are still fighting against an incredibly deadly mechanism.
That is the core frustrating challenge, isn't it? You see all these headlines about miracle devices and procedures in cardiology, and yet when the heart truly fails, the data suggests we are still facing, well, truly dire odds.
We are. The single startling core statistic that defines this entire crisis is the mortality rate. Despite everything, 30-day mortality for cardiogenic shock remains stubbornly high, ranging from 40% to 50% after the onset of shock. It is the leading cause of death among hospitalized patients who suffer a myocardial infarction or, a heart attack.
That means that roughly 1 in 2 people who fall into this state
Don't survive the month.
That is just a devastating figure. So our goal today is to go far beyond the basics. We really need to unpack the recent paradigm shifts, what advances in diagnosis and, crucially, management have finally yielded evidence-based strategies proven to decrease that mortality rate.
We have to focus on the evidence, which frankly often contradicts older medical dogma. We'll be looking at things that are proven to work, like the urgency of revascularization for this culprit lesion and heart attack-related shock, and the highly specific, meticulous use of advanced mechanical circulatory support, particularly the microaxial flow pumps, which have recently shown a breakthrough benefit in a very carefully selected patient group.
Okay, let's unpack this and establish the foundation. We'll start by asking, how do we even define cardiogenic shock, and what does that downward spiral of its pathology look like in clinical terms? For a condition so severe, you would think the definition would be simple, but the presentation is so variable that the field has had to work hard to standardize the criteria. We're looking at the formal definition put forth by the Shock Academic Research Consortium, or SHARC.
Standardization is absolutely vital because for years, heterogeneity in how different hospitals define shock made comparing studies nearly impossible. SHARC provides a consensus. Cardiogenic shock is defined as a cardiac disorder that results in both clinical and biochemical evidence of sustained tissue hypoperfusion. So the focus isn't just on the heart, but on the downstream consequence, which is inadequate oxygen delivery to the tissues.
And to make the diagnosis, you have to have 4 key non-negotiable elements. The first one relates to blood pressure control.
Yes. You must have established hypotension or the need to intervene to prevent it. Specifically, the systolic blood pressure, the SBP, must be less than 90 millimeter Hg for a sustained period, so over 30 minutes, or the patient must require continuous support.
Meaning drugs or a machine.
Exactly, meaning the use of inotropes, vasopressors, or mechanical circulatory support just to keep that SBP at or above 90. The clinical system is either already failing or it's being held together by maximum intervention.
The second element moves beyond the monitor and requires the clinical evidence of systemic hypoperfusion.
This is what clinicians observe right at the bedside. You look for signs that blood is not reaching the periphery or the vital organs. So the patient presents with cold or clammy, poorly perfused extremities. They might show reduced urine output oliguria, or crucially, they may show signs of altered mental status, which indicates a lack of blood flow to the brain, and that is one of the most worrying signs.
Third, we bring in the lab work, confirming the failure at a cellular level.
Right. We look for biochemical evidence of oxygen deprivation in the tissues, what we call tissue hypoxemia. The gold standard biomarker for this is an elevated arterial lactate level, typically greater than 2 millimol. This signals that the body has shifted into anaerobic metabolism because it simply isn't getting enough oxygen.
And finally, to confirm the cardiac origin, you need imaging.
An echocardiogram is required to demonstrate cardiac dysfunction. This is necessary to differentiate cardiogenic shock from other forms of shock, like septic shock or hemorrhagic shock, where the pump itself is often fine, but the volume or the vascular tone is the problem.
It's also really important to understand the variations because not every patient in cardiac trouble fits that textbook definition. So tell us about normotensive cardiogenic shock.
This is a challenging diagnosis.
Yeah.
These patients, they maintain a systolic blood pressure over 90, perhaps through tremendous compensatory vasoconstriction, but they still have clear clinical and biochemical evidence of organ hypoperfusion.
So they look okay on the monitor, but they're not.
Exactly. They're still showing high lactate and signs of end organ damage. Their compensation is hiding the underlying pump failure.
And then there's the incredibly complex mixed shock.
Mixed shock is common and particularly lethal, as the registry data we'll talk about will show. This is where cardiogenic shock exists simultaneously with at least one other major cause of shock. Maybe a patient suffering a heart attack, then develops a severe infection, leading to septic shock coexisting with their cardiogenic failure. This combination of vascular collapse and pump failure makes treatment protocols extraordinarily complex because you're chasing two different diseases at once.
Beyond these clinical criteria, what are the distinct mechanical characteristics of true cardiogenic shock, often measured with a right heart catheterization?
So if you're able to invasively monitor the patient, you confirm the diagnosis hemodynamically. Established CS is often defined by a low cardiac index, which is the measure of cardiac output adjusted for body surface area, at or below 2.2 liters per minute per square meter. This low flow is frequently seen in combination with signs of the body fighting back. A high systemic vascular resistance index, often over 2200. So it paints this picture of a weak, failing pump, the low index struggling against an extremely high load or high resistance.
And here's where the narrative of collapse truly unfolds. The pathophysiology described as a deleterious downward spiral. How does the initial event cascade into total systemic failure in this self-sustaining loop?
It's a cruel positive feedback mechanism. It starts with a mechanical injury, say, a massive heart attack that profoundly decreases cardiac function. The low output immediately causes low systemic blood pressure. Low pressure means inadequate flow to every organ, including the heart's own blood supply, the coronary arteries.
So the heart muscle becomes starved of oxygen, which just makes it even weaker.
Exactly. That coronary ischemia further decreases contractility, which reduces the cardiac index even more. This feeds back into lower systemic blood pressure, which deepens the ischemia. The heart is literally starving itself into failure. This mechanical loop is what makes CS so immediately lethal.
And meanwhile, the body is attempting its own immediate fix.
The initial reaction is compensatory systemic vasoconstriction. The body squeezes the blood vessels to try and raise that vital blood pressure and shunt blood to the most critical organs. But for the failing heart, this is disastrous. It increases the afterload, the resistance the weak ventricle has to pump against, and it just fatigues it even faster.
And that compensatory phase doesn't last, which then leads to the inflammatory shift.
Eventually, the systemic inflammatory response takes over.
Yeah.
The profound tissue hypoxemia and the release of inflammatory mediator cytokines cause pathological vasodilation. The vessels relax, blood pressure tanks, and the patient shifts from a low-flow, high-resistance state to a massive inflammatory shock state, where even if the pump function improves slightly, the vessels are too leaky and dilated to maintain perfusion pressure.
And that lack of oxygen delivery, the sustained tissue hypoxemia evidenced by the soaring lactate, is what drives the inevitable multi-organ failure that kills the patient.
That is the ultimate consequence. We see failure across every major system. The kidneys are severely affected by hypoperfusion, leading to acute tubular necrosis and often requiring renal replacement therapy. The liver suffers from hypoxic hepatitis. You see rising AST and ALT enzymes. The lungs develop pulmonary injury and congestion, which is compounded by the primary cardiac failure.
And the gut plays a really dangerous role in accelerating the systemic collapse, doesn't it?
It absolutely does. Severe hypoperfusion causes the gut lining to lose its integrity, which allows for bacterial translocation. So bacteria move from the gut into the bloodstream. This significantly exacerbates the systemic inflammatory response syndrome, or SIRS, driving that late-stage pathological vasodilation we just discussed.
So we're not just treating a failed heart. We are fighting a whole-body inflammatory catastrophe.
Precisely. The microvascular system itself breaks down, with endothelial swelling, stasis, and microthrombi forming, which further hinders oxygen delivery even to the perfused organs. Clinically, we monitor the consequences: rising lactate, high cardiac troponin signaling, continued myocardial injury, and increased markers like BNP and CRP, all signaling this massive systemic insult and correlating very strongly with a poor prognosis. It's a multi-system breakdown ignited by the pump failure.
Given this incredibly rapid, dynamic, and heterogeneous process where one patient might progress slowly and another might crash immediately, there was a huge clinical need for a common language, and that's where the SKAI staging system comes in, providing a standardized way to grade shock severity.
It has become a vital clinical and research tool. Developed by the Society for Cardiovascular Angiography and Interventions, the SKAI system provides 5 stages, A through E, to grade the spectrum of shock. It allows clinicians to communicate severity quickly and helps researchers compare cohorts more accurately.
So let's walk through them, thinking about the clinical implications of moving from one stage to the next. Stage A is at risk, where the patient is predisposed, maybe they had a big heart attack, but no signs of shock yet.
Stage B is pre-shock or beginning shock. Here the patient is starting to decompensate, showing clinical evidence of relative hypotension or tachycardia. But the crucial distinction here is that they have no clear signs of hypoperfusion yet. Their lactate is often still normal or just mildly elevated.
Okay, so you're starting to see trouble, but no actual end organ damage yet.
Exactly.
Then we reach the established state, stage C, or classic shock.
Stage C is where the diagnosis is confirmed. You have a lactate level greater than 2, a low cardiac index, and often high pulmonary capillary wedge pressure, confirming fluid backup and pump failure. This patient requires significant intervention.
And the progression from C to D is often the difference between survival and death, and the clinical stress in the ICU rapidly escalates here. Stage D is deteriorating shock. What does that increasing intensity really look like?
Stage D means the patient is failing despite aggressive treatment. They're deteriorating, so they require escalating treatment intensity. This might mean continually rising doses of vasopressors, the addition of a second inotrope, or, critically, the initiation of mechanical circulatory support. Their lactate levels are consistently high or still climbing, showing that their current support strategy is insufficient. This is the point where the multidisciplinary shock team is often activating their maximum resources.
And finally, stage E, extreme shock.
Stage E represents a profound, near irreversible collapse. These patients are in profound hypotension despite receiving maximal hemodynamic support. They might be on high-dose pressors and a high-output MCS device. They typically have lactate levels soaring above 8 millimole per liter, often suffering acute respiratory or renal failure. Prognosis in stage E is extremely poor.
While practical, you mentioned the SKAI system has its limitations.
Yes. While it's excellent for grading overall severity, its limitations really stem from the dynamic nature of CS. The patient might move from C to D and then back to C over a few hours. This requires frequent reassessment, ideally twice a day. Furthermore, the criteria for escalating treatment intensity can be somewhat subjective, which makes precise comparisons difficult across different hospitals and research studies. It guides management well, but it's not a perfect prognostic tool for an individual patient.
Let's move to the underlying causes. We broadly categorize them into acute myocardial infarction shock, non-infarction-related factors, and secondary causes.
And what's fascinating here is the major epidemiological shift that has defined the last decade of cardiogenic shock management. For many, many years, the immediate consequence of a massive heart attack was the dominant cause.
But that's changed due to better primary care for AMI.
Exactly. Due to massive improvements in prevention, better management of risk factors, and the widespread adoption of faster, earlier revascularization for heart attack patients, the relative proportion of infarct-related shock is now decreasing.
So non-infarction-related cardiogenic shock, primarily heart failure, either new onset or acute decompensation of chronic failure, now actually outnumbers AMI-related cases.
That is the current reality in many registries. Heart failure is the new dominant etiology. However, infarct-related CS still carries the highest immediate mortality risk.
And that's borne out by the specific registry analysis cited in the source, looking at nearly 9,000 patients. The cause dictates the prognosis profoundly.
The data is stark. Infarct-related shock had a mortality of 41%. New heart failure stood around 31%, and acute on chronic heart failure was the lowest at 25%. But the worst prognosis belonged to mixed-cause cardiogenic shock, which topped the list with 48% mortality. When you have 2 or more system failures driving the shock, your odds just drop instantly.
And when we look at why patients die, we have to remember the multi-organ fallout.
Right. While persistent cardiogenic shock is the most common cause of death, it's rapidly followed by consequences like arrhythmia, respiratory failure, and significantly anoxic brain injury. In many cases, the cause of death is recorded as withdrawal of life support due to futility related to irreversible multi-organ damage.
Let's talk about phenotyping, starting with the mechanical failures. Left ventricular failure is primary, but right ventricular involvement is common, and it makes fluid management so much more complicated.
Biventricular failure is the rule, not the exception. RV involvement was seen in 44% of infarct-related CS patients, and it's even more frequent in non-infarction-related shock. The RV is thin-walled, and it's very sensitive to increases in pulmonary pressure, which congestion inevitably causes. If the RV fails, you can't push blood into the lungs, meaning venous return is stalled, making the patient acutely sensitive to fluid and complicating ventilator management.
We also need to recognize those specific, devastating mechanical complications that require an immediate surgical fix, not just drugs.
These are rare, but they are catastrophic structural failures, like a ventricular septal wall rupture, a hole forming between the heart chambers, or acute mitral regurgitation due to papillary muscle rupture. These carry a dismal prognosis unless they are definitively corrected, often surgically within hours.
And finally, let's revisit that really challenging group, the post-cardiac arrest comatose patient.
This group adds significant noise to trial data. They often have reduced cardiac function or stunning after their circulation returns. They're intubated, sedated, and require vasopressors. But here is the major clinical paradox. The initial high lactate levels often seen in these patients are not necessarily due to current pump failure. They're the result of the massive, prolonged systemic ischemia during the time they had no flow or slow flow.
So a high lactate here is historical evidence of damage, not necessarily an accurate marker of current cardiac output.
Exactly. It doesn't correlate well with the cardiac index. This makes assessing the effectiveness of immediate shock treatment very difficult. Worse, 20% to 30% of these patients will die from anoxic brain injury, even if the circulatory support is successful. This means that including these patients in device trials can dilute the observed benefit for patients whose primary problem is purely cardiac.
Which brings us back to prognostication. Despite all the staging systems, mortality prediction remains difficult.
It does. While complex prognostic scoring systems exist, the SKAI staging system, A through E, remains the most practical bedside tool for assessing overall population mortality trends. But for the individual patient, it's imprecise. We still rely heavily on clinical judgment, lactate clearance, and evidence of end organ damage stabilization.
This brings us to management. And before we even discuss drugs or devices, success in treating cardiogenic shock seems to hinge less on a specific technology and more on the system of care itself.
That is the most reliable, evidence-based intervention we have. Observational studies consistently demonstrate significantly lower mortality rates when patients are treated at specialized high-volume tertiary care centers. These facilities must be equipped with dedicated cardiac ICUs, 247 cardiac surgery, and crucially, the ability to initiate and manage every level of mechanical circulatory support on site.
And this centralization of care supports the vital shock team concept.
A multidisciplinary approach is absolutely mandatory for a rapid response. A specialized shock team comprising intensivists, interventional cardiologists, perfusionists, and surgeons working within regionalized shock care systems has proven to be an independent factor associated with improved patient outcomes. Time is tissue, and a coordinated, expert team reduces delays and improves the quality of every decision made under extreme pressure.
Okay, so let's look at general intensive care treatment. Beyond the standard supportive care like blood glucose control and prophylaxis, how is the team tracking perfusion stabilization?
Lactate monitoring is key, and it has to be aggressive. It needs to be measured frequently, often hourly, until a definitive trend towards stabilization or clearance is achieved. Lactate clearance, showing the body is returning to aerobic metabolism, is a stronger positive prognostic indicator than just achieving a target blood pressure.
And for those patients who require mechanical ventilation, which is common, lung protective strategies are non-negotiable.
Absolutely. The goal is to minimize lung injury, typically achieved by using a tidal volume of 6 to 8 milliliters per kilogram of predicted body weight. But the team must be cautious with positive pressure ventilation. If the patient has dominant right heart failure, positive pressure can impede the return of blood flow to the heart, further destabilizing the RV.
So non-invasive ventilation might be out.
Sometimes it has to be avoided entirely in those phenotypes.
And given the prevalence of acute kidney injury from hypoperfusion, renal replacement therapy, or RRT is often necessary.
It is, frequently. RRT is required for classic acute indications. Acute renal failure with signs of uremia, metabolic acidosis that can't be corrected, refractory hyperkalemia, or overwhelming volume overload and pulmonary edema that diuretics can't handle. In major CS trials, the need for RRT ranged from 11% to 18%.
The major open question here, though, is the timing. So is there a benefit to starting it early before the critical indications are met?
This is a widely debated topic. Interestingly, randomized trials comparing accelerated proactive RRT initiation versus delayed initiation, so waiting for conventional emergent indications, have generally shown no difference in overall patient outcome, including mortality. So while RRT is necessary when the indications are met, the evidence currently suggests that initiating RRT prophylactically or very early simply because the patient is in shock doesn't necessarily improve survival.
Now we shift to the pharmacologic balancing act of fluids, inotropes, and vasopressors. Starting with fluids, the temptation in low-pressure shock is to simply give a massive fluid bolus. Why is that often so detrimental?
Because the heart is failing due to pump capacity, not usually due to blood volume deficiency alone. While avoiding absolute hypovolemia is critical, aggressive fluid resuscitation can be disastrous. It leads to overwhelming pulmonary congestion, increasing the pressure in the lungs, and acutely worsening both left and right heart failure.
So how do clinicians determine if a patient is fluid responsive?
They have to differentiate central hypovolemia without congestion. A passive leg raise test is often used, where briefly raising the patient's legs mobilizes volume and simulates a fluid bolus. If hemodynamics improve temporarily, they may benefit from a small crystalloid solution bolus. But if the patient is already congested or has high pulmonary capillary wedge pressures, the priority shifts immediately to reducing volume using loop diuretics to manage the pulmonary edema.
Moving to inotropes, drugs that boost the heart's squeeze. This is an area, frustratingly, without a strong evidence-based consensus for a first-line agent.
The clinical choice remains incredibly variable. Dobutamine is probably the most commonly used agent, primarily for left ventricular failure. Its role is to increase contractility. Alternatives include milrinone, a PDE3 inhibitor, and levosimendan, a calcium sensitizer, both of which also offer some vasodilatory effects which can help reduce afterload.
But the critical evidence gap remains. None of these agents have definitively shown a mortality benefit over the others in major randomized trials.
That is the hard truth. Randomized trials comparing agents like milrinone and dobutamine found no significant difference in outcomes. A rigorous Cochrane analysis concluded there is insufficient evidence to establish the superiority of any single inotrope regarding mortality reduction. We're forced to rely on agents that improve hemodynamics in the short term, hoping to buy time, without the certainty that they actually improve long-term survival.
So what does this all mean for supporting blood pressure? If the inotropes aren't definitively solving the problem, we have to rely heavily on vasopressors to maintain adequate perfusion pressure to the organs.
And this is one pharmacologic area where the data is actually pretty clear. Norepinephrine is the vasoconstrictor of choice. It provides effective vasoconstriction to raise the mean arterial pressure, or MAP, with minimal unwanted side effects compared to historical alternatives.
Okay, so tell us the evidence against the other main options, dopamine and epinephrine. Why has norepinephrine emerged as the superior choice?
The evidence against dopamine is compelling. When patients were randomized across various shock types, those treated with dopamine suffered substantially more arrhythmic events, dangerous, irregular heart rhythms, compared to those on norepinephrine without showing any superior mortality benefit. Dopamine just introduces unnecessary risk.
And epinephrine, that's often considered a really powerful agent.
Epinephrine also falls out of favor. While it might achieve similar hemodynamic effects to norepinephrine, it has unfavorable effects on heart rate. It can cause excessive tachycardia, and critically, it exacerbates metabolic changes, often worsening lactic acidosis, which is the very marker we are desperately trying to clear. Norepinephrine minimizes these complications.
And that target is usually a mean arterial pressure greater than 65 millimeter Hg.
Correct. That 65 target ensures adequate perfusion pressure for most vital organs. However, it's worth noting that research continues. Ongoing trials are currently testing if a slightly lower MAP target, maybe 55, might be sufficient in infarct-related CS. The hypothesis is that a lower target could reduce the total dose of pressors needed, but for now, 65 remains the standard.
If pharmacologic support fails, we enter the realm of temporary percutaneous mechanical circulatory support, or MCS. This is the moment we bring in the machines to provide assistance, sometimes replacing the heart's function entirely.
MCS represents the maximum intensity of support. Its purpose is purely temporary stabilization, to improve hemodynamics and enhance organ perfusion, while the team either treats the underlying cause, like opening a blocked artery, or decides on a long-term solution. We often categorize its use as a bridge to cardiac recovery, a bridge to a durable device like an LVAD, or a bridge to heart transplantation.
And the critical dilemma here is the trade-off. We're balancing the massive potential for life-saving efficacy against the incredibly high risks of device-related complications, not to mention the high institutional expertise required. So let's review the evidence on the major devices, starting with the intra-aortic balloon pump, or IABP.
The IABP is the oldest and simplest device. It has the most favorable profile in terms of low cost, ease of insertion, and fewer adverse events compared to the larger pumps. It offers modest support by inflating during diastole to boost coronary blood flow and deflating rapidly during systole to reduce the afterload.
But this is one of our first major paradigm shifts. Despite being the historical standard of care, the data is decisively against its routine use.
Absolutely. The landmark IABP SHH-02 trial, focusing on infarct-related CS, was conclusive. It found that the routine use of IABPs provided no survival benefit compared to optimal medical therapy alone. The ULCHOC-2 trial later confirmed this neutrality in heart failure CS. So because it doesn't offer enough flow or pressure generation for established severe shock, it's generally not recommended for routine use.
Okay, next, the big gun. Veno-arterial extracorporeal membrane oxygenation, or VA-ECMO. This provides the highest level of support, capable of full circulatory and respiratory assistance.
VA-ECMO can deliver high flow up to 6 liters per minute, bypassing the heart and lungs entirely. Blood is drawn from a vein, oxygenated externally, and returned via an artery, typically into the aorta. Its use has exploded globally, but once again, the randomized evidence failed to support the enthusiasm.
And the recent ECLS SHO-CA trial specifically examined early, routine VA ECMO in severe infarct-related CS patients. What was the outcome?
Another neutral result. The trial found no significant difference in 30-day mortality between the VA ECMO group and the standard treatment group. This neutrality was sustained at the 1-year follow-up. This finding was consistent with meta-analyses which showed no mortality benefit but did identify a higher rate of complications associated with device use.
So another big device that didn't really deliver in the trials. Now, this is a crucial clinical nuance that has to be understood. VA ECMO, while providing massive flow, can paradoxically harm the failing heart. How does that afterload paradox work?
It's a physics problem. VA ECMO returns highly oxygenated blood in a retrograde fashion against the normal flow into the aorta. This creates an extremely high pressure or resistance that the left ventricle has to pump against. For a ventricle that is already stunned and failing, this massively increased afterload can increase LV wall stress, increase myocardial oxygen consumption, and actually worsen the heart's recovery.
So it helps the body, but can actually hurt the heart.
It can, potentially leading to pulmonary congestion and stasis. And this inherent risk is what led to the strategy of active left ventricular unloading.
To counteract the afterload increase, clinicians often add a secondary device to actively drain or pump blood out of the left ventricle. This might be an IABP or a microaxial flow pump used specifically for unloading. But while observational studies suggested this combined strategy might lower mortality, the randomized evidence remains neutral. The early unload trial failed to show a difference in mortality. We are still awaiting definitive proof that adding a second device to mitigate the harm of the first device is truly beneficial.
And here's where it gets really interesting, because the narrative shifts with the microaxial flow pumps, like Impella. These devices, which can provide up to 4.3 liters per minute of flow, primarily for left ventricular support, finally gave us a positive randomized result.
This is the true breakthrough in recent memory, but it came after years of skepticism. Earlier, propensity-matched studies were neutral and often reported higher complication rates, fueling the idea that MCS devices were just too dangerous for a generalized shock population. But the Danger Shock trial, published in 2023, changed the landscape because of its incredibly specific, meticulous patient selection.
Danger Shock's success was entirely due to its tight inclusion criteria. They randomized 360 patients with STEMI-related CS, but they specifically excluded the highest-risk patients, those with prolonged cardiac arrest or those at risk for hypoxic brain injury, Stage E patients. By focusing on patients with LV-dominant shock and better baseline neurological status, they found a significant measurable benefit. The microaxial flow pump led to lower all-cause mortality at 180 days.
A 26% reduction in the risk of death at 6 months for this specific group. That's massive. And you mentioned this benefit was sustained.
It was, which is critical.
Yeah.
The long-term follow-up showed that this mortality benefit was sustained for up to 10 years, suggesting that using the device early in the right patient population allows the heart to recover sufficiently for a sustained survival advantage. It proves that there is a time and place for aggressive MCS.
But we have to balance that success against the trade-offs, which were significant even in this successful trial.
The trade-offs were severe. The microaxial pump group in the DanGer trial had significantly higher rates of major device-associated complications, higher rates of severe bleeding, more instances of limb ischemia requiring vascular repair, and an increased need for renal replacement therapy. These devices are powerful, but they are not benign.
So the critical lesson is that MCS works, but only when you restrict its use to a low-risk subgroup of patients with LV-dominant shock, making it a Class VRI indication.
Absolutely. We have to reinforce the need for patient selection because the complications are so serious. Registry data reminds us that 50% to 60% of infarct-related CS patients will actually survive without any mechanical device. Using a complication-heavy device in that subgroup exposes them to unnecessary risk.
And conversely, for patients in stage E, shock, those with profound collapse, advanced age, frailty, or confirmed anoxic brain injury, the devices offer no benefit.
That's the tragedy. The eligibility criteria for the DanGer Shock trial, the successful criteria, were so restrictive that recent analysis suggests only 5% of all cardiogenic shock patients, or about 1/3 of STEMI CS patients, would be considered appropriate candidates. MCS is a powerful tool, but it is highly specialized and it is not a routine therapy.
While MCS buys time, the ultimate goal in AMI-related CS is always to fix the underlying plumbing problem, revascularization. Let's look at the evidence for urgency.
Early revascularization is highly recommended. The seminal SHOCA trial, published way back in 1999, initially showed no reduction in 30-day mortality with emergent revascularization compared to initial medical stabilization. And this was confusing at the time.
But the long-term follow-up changed the interpretation entirely.
It did. The long-term follow-up showed that early revascularization did reduce mortality over the longer term, a benefit sustained up to 6 years. This taught the field that the intervention is necessary for survival, even if the immediate benefit isn't seen in the first 2 critical weeks. Therefore, any delay in opening the blocked artery is associated with significantly worse clinical outcomes.
So the immediate standard of care is to get the patient to the cath lab immediately. But for patients with very prolonged transfer times, there is an alternative approach.
Yes. For STEMI CS patients facing long inter-hospital transfer, the concept of a pharmacoinvasive approach giving fibrinolysis, so clot-busting drugs, followed by timely PCI, has shown clinical benefit. This allows for initial reperfusion without increasing the risk of major bleeding, offering a valuable interim strategy.
Now, we face the major clinical quandary, which affects up to 80% of infarct-related CS patients, the multivessel dilemma. If the patient has multiple narrowed arteries, should the interventionalist treat only the one causing the heart attack, the culprit lesion, or fix all of them immediately?
This question required a major randomized trial, and the culprit shock trial provided a clear, counterintuitive answer that dramatically changed practice. The trial showed a significant clinical benefit for culprit lesion-only PCI compared with immediate multivessel PCI.
That is the ultimate paradox. In almost every other situation, you want to fix all the blockages. So why is performing immediate multivessel PCI harmful in a patient already in severe shock?
There are several critical rationales. First, time. A comprehensive multivessel PCI is complex and time-consuming. Every minute spent on a non-culprit lesion in the cath lab is time the patient's organs are underperfused and hypoxic. Second, contrast load. Treating multiple lesions requires more iodinated contrast dye, which is nephrotoxic. It's toxic to the already struggling kidneys. And third, stress. Prolonging the procedure introduces more stress and potential for instability in a critically ill patient.
So the study results were unambiguous about the harm of over-treating in the acute phase.
They were. The culprit lesion-only group had a significantly lower rate of the composite endpoint of death or renal replacement therapy, 45.9% versus 55.4% for the immediate multivessel PCI group. The primary driver of this difference was lower mortality in the culprit lesion-only group.
Therefore, the current best practice, derived directly from culprit shock, is a staged approach.
Precisely. The preferred strategy is culprit lesion-only PCI in the acute setting to stabilize the primary cause. Then, once the patient achieves clinical stabilization and the shock state is reversed, often days or weeks later, they can undergo staged revascularization of the non-culprit lesions.
Finally, just to briefly revisit the mechanical complications, these structural failures require a completely different, definitive approach.
Yes. Ventricular septal wall rupture or papillary muscle rupture are not amenable to PCI alone. They carry a dismal prognosis. Mortality approaches 90% without intervention and require immediate definitive surgical or complex percutaneous correction to prevent immediate patient death. They represent a distinct, highly acute surgical problem.
So we've established that despite major breakthroughs in devices and revascularization strategies, the field is still facing this 40% to 50% mortality rate. Looking forward, what are the inherent difficulties in conducting better research and driving down those numbers further?
The research challenge is immense, and it's threefold. First, the acuity and severity of the condition make obtaining informed consent difficult and introduces major ethical constraints. Second, the sheer heterogeneity of patients is a massive obstacle. We are throwing left heart failure, right heart failure, post-cardiac arrest, and mechanical complications all into the same bucket.
And that diversity of phenotypes may well explain why so many previous randomized trials, like those for IABP or VA ECMO, yielded neutral results.
Exactly. If you successfully treat a patient whose primary issue is RV failure with a strategy designed for LV failure, you might negate the potential benefit seen in the LV failure subgroup. The treatments have to be tailored to the specific phenotype.
So the primary need moving forward is not necessarily a new drug, but smarter stratification advanced phenotyping.
Absolutely. We need sophisticated diagnostic tools going beyond just the SKAI staging to accurately distinguish these subgroups. We need to identify biomarkers and imaging characteristics that tell us precisely which patients belong to which phenotype and therefore who will benefit from targeted therapeutic strategies.
And this necessitates major collaboration to answer these remaining open questions.
Yes. We require large international shock research networks to pool data. There are still multiple unknowns. What are the optimal parameters for effective device escalation? If a patient fails one MCS device, when and how should we upgrade? And just as critically, what are the protocols for safe de-escalation and weaning patients off support? We also need better data on complication management and, increasingly, the long-term cost-effectiveness of these incredibly expensive treatments.
Before we close, let's distill the essential nuggets for our listener, the key takeaways that define the modern management of cardiogenic shock based on the latest evidence.
First, the overarching reality. Mortality remains stubbornly high, often near 50%. Second, know the non-starters. IABP and routine use of VA ECMO have not proven beneficial in reducing mortality, and the latter carries a risk of increasing afterload.
Third, on the pharmacologic front, there is a clear winner.
Norepinephrine is superior to both dopamine due to arrhythmias and epinephrine due to metabolic consequences for supporting blood pressure.
Fourth, when fixing the underlying cause in AMI-related shock, the specific strategy matters.
For multivessel disease, only the culprit lesion should be treated in the acute setting, followed by staged PCI after stabilization.
And finally, the massive recent success of microaxial flow pumps is entirely dependent on meticulous, restrictive patient selection.
The benefit is only seen in a small subgroup of patients with LV-dominant shock who have a low risk of anoxic brain injury.
So in summary, modern cardiogenic shock management is less about deploying the biggest, most aggressive device on every critically ill patient and much more about highly sophisticated, evidence-based selection, targeted coronary intervention, and rigorous, coordinated supportive care in a specialized multidisciplinary center.
It is.
That leads perfectly to our final provocative thought for you to consider. The compelling evidence from trials like danger shock and culprit shock suggests that in this hyperacute life-or-death scenario, knowing when not to initiate an aggressive and complication-heavy intervention, knowing who will survive simply with optimized standard care and early reperfusion, might be just as important and perhaps more ethically defining than knowing when to use the most powerful technology available. Thank you for watching The Funnel Effect.